Hi everyone, my name is Xiao from University of Arizona. Today I'm going to present my study using social media to detect adverse drug events. So adverse drug events is defined as injuries resulting from drug-related medical intervention. It is the fourth leading cause of mortality in the United States. And to address the issues of drug safety and protect the patient from adverse drug events, drug regulatory agencies started to take actions. They started to build up this post-marketing surveillance program, which aimed to accumulate evidence of adverse drug events and to conduct interventions to take risky drugs out of the market when they detect a signal. So in year 2004, FDA started their spontaneous reporting system. They built a system called FDA's Adverse Event Reporting System, which is a system collecting voluntary reports regarding to adverse drug events happen to patients. Doctors, consumers, healthcare consumers, and the drug companies can send report to this system. And over the years, researchers trying to utilize this database to identify risky drugs from the market, but they have identified several drawbacks from this system. The first one is, since it's a voluntary report system, there is a very high underreporting rate. So according to a study in 2006, there are 94% of the adverse drug events never reported to FDA. And another potential issue is, since the system collected reports of adverse drug events, and there is no evidence about how many patients take the specific medication but never experienced a particular adverse drug event. So to address this issue, researchers are looking into using other data sources such as social media to find potential information that they can utilize to identify signals of adverse drug events. So the picture in my slides show a snapshot of discussions related to Afrenza, which is a drug recently released to the market treating diabetes. And it's an inhaled insulin treatment, which is a new kind of treatment, which is very popular among patients because it's easy to use and patients do not have to carry a needle to inject. But however, this drug has causing some problems to patients. For example, people report coughing and pain after using this treatment. So since social media has shown evidence of containing discussion about adverse drug events, we're thinking about develop an information system that can extract this kind of information from social media. So our approach starts from data collection. We look into different kind of social media platforms such as Twitter and forums. And we try to collect the data from external knowledge base as a baseline or evaluation method for our extraction. And then we conduct a data preprocessing, which aim to extract medical entities such as drug names and the medical conditions from the tweets. As shown in the example here, we're looking for Afrenza as a drug name or Actos as a diabetes treatment name in the discussions. And we also try to use the medical entity extraction to identify what kind of medical conditions patients are discussing in their social media. And the second part is called co-reference resolution. It aims to identify terms that cross-reference in different sentences, as the example shown in instance 2. And we also use syntactic parsing to generate features to represent each instance. And in the model part, we propose to use a distance supervision model to extract the adverse drug event from the social media. So the distance supervision process is a little bit different from the traditional supervised machine learning approach, which generates the label for training corpus using existing knowledge from a knowledge base. For example, if we have observed a lot of reports about Actos and the weight gain in the FDA's report database, we're going to label this instance as an adverse drug event. And use this approach, we are able to generate a large amount of training data with very low cost and without manual effort. And in the evaluation process, we try to do two types of evaluation. First, we hold out part of the knowledge in FDA's database and try to run the model with the hold of data and to evaluate the system with the rest half of the knowledge we have. And the second part, we want to evaluate how precise that our extraction system are. So we develop a gold standard data set that we can compare the performance of our approach to the human annotated result. So our data set is collected from online forum of American Diabetes Association, and we collected tweets from Twitter for a 6-month period containing about 40 diabetes drugs. And we also look into the FDA's database to extract the subsets related to diabetes treatment. So our results show that our approach achieved about 70% of precision in extract adverse drug events in forums and about 63% in extract event from Twitter datasets. And we choose diabetes as a research case in this situation because diabetes cover a large patient group in the United States. And we want to look into the treatment with, I will finish it really quick. So we look into the treatment about Avandia, which is a very high profile drugs for diabetes treatment. So it is reported for increased the risk of heart attack in 2007, and FDA announced the restriction to use this medication in 2010. And after all, the restriction was removed in 2013, so there's a lot of discussion regarding whether this drug actually causes heart attack. So we look into the forum discussion we have. We found that although there are a lot of discussions about Avandia, but actually only a small amount of patients actually report they experienced heart attack. But we look into the Twitter discussion, and large amount of discussions related to Avandia confirm that there's a heart attack event happen to patients use that. And the second research case we look into is the drug called Afrenza, which is a recently marketed inhaled insulin treatment. We obtained 127 reports of drug indications or adverse events in our data set. But at the same time, FDA only have one case report regarding to Afrenza in their database. So we found that we can actually identify adverse drug events related to medications ahead of time, particularly for new treatments. And we also find that we can use distance supervision approach as an alternative approach for supervised learning. And we also confirmed the strengths and weakness of different data sources in identifying adverse drug events in this study. That's all.
So, hello everybody. My name is Adel Yazdanmer. I'm from University of Texas at Arlington. I want to thank you for the opportunity to give me this stage to talk about my project. And this is the first time I participate in any kind of healthcare project. It's a little bit sad to see lots of people left the room, so just we move on. So, because I had a big question, I want to ask you. Yeah, I had a big question. I wanted to engage every audience. So anyway, so let's move on. So I wanted to ask you, how many of you are willing to sell your private personal information? So, and how much?
I gave it to a Nigerian prince for free.
Okay.
Well, I'm going to get a lot from it.
So, as you can see, there are, the majority of the audience don't like to share their personal health information. And that's the case in the lots of literature. Everybody talks about how sensitive these health information and other stuff like social security number is. But what if I tell you there is a place that people go and share their information and every aspect of it, and without expecting like any monetary or any like a money term reward. So this is kind of a privacy paradox. You have lots of privacy concern about your health information, but you go there and you reveal that. So we want to know why people do that. So the reason that the way that the angle we are going to look at this problem is through privacy calculus. So we want to see what kind of cost is related with the disclosing your information on online portals, online patient portals, and what kind of benefits you will get. So about the benefits, whenever patient understand there is a disease, there is something wrong, there are a couple of approaches that they take. There are a couple of strategies. One of them is emotional preoccupation, which means that they want to know, is there any other person who has the same situation? They want to get emotional support. The other thing is they want to get information. They want to see what's the treatment, what's the thing going on, how can they cope with this issue. Okay, so, but there's also lots of privacy concerns. Okay, so for example, if you look at this chart, this picture, you can see I can find a person who shares information online on one of these patient communities with all his disease, its symptoms, everything on a LinkedIn. So it's identifiable. The other thing is you don't know who uses your information. So, for example, Patient Like Me is one of these online portals. They were attacked by some of these companies, and their data was scrapped and lost. But again, there is lots of benefits. As you can see here, there is emotional support and there is informational support. And by the way, this is the wrong slide.
We wouldn't have known.
Yes, so this is the demographic of our data. So we had a data page. Our data is 883 patients from Patient Like Me online community. We downloaded all of those patients with their profile, pages, posters, everything. And they are lung cancer patients with their situation unresolved, diagnosed and unresolved. And we look at their number of posts they put, the number of updates, comments, what kind of feedbacks they get. And since I'm running out of time, I'm going to go through it very fast. We found out that as we expected, age, gender, and other like membership days, these are the control variables, are significant. I mean, gender is not significant because our data is kind of biased toward the women. They are 75% women in our data set, which in reality is 55%, 45% only of women have the lung cancer. So it's kind of maybe because of that, but as you can see, our informational interest and informational interest is significant, which means that the more you are interested in getting information, you will share more posts. And the stage of the disease, which stage you are in, the first stage, second stage, third, and fourth, the first stage is the stage that it's almost curable, so you can be cured. The fourth stage is the one that's kind of you're disappointed. So we found that like a bell-shaped kind of things that if you're in the first stage, you want to get more informational support. And if you're in the fourth stage, which is the deadliest stage, you want to get more emotional support, so like empathy. So for future research, we are going to look at what is content of this post and the dynamics of these posts. Thank you very much. I'm so sorry for...
My name is Paul Abernathy. I'm the CEO of the Focus Pittsburgh Free Health Center. I'm not a researcher. I'm the community partner with Dr. Zhao at the University of Pittsburgh, and the premise that we actually started off with is looking at the role that trauma has in affecting health outcomes in our community. You know, we live in a community that's not only medically underserved, but it is a trauma-affected community. And one of the things that we've seen over recent decades is how the amount of money that has been invested in our community hasn't had the impact that we had all hoped. And one of the reasons is because trauma, as we know from the ACE study, Adverse Childhood Experiences, has a tremendously profound effect on the health of the person. This is why we've entered into this relationship to give some effort to make the investment in our community have a more meaningful impact. What do we mean by trauma? We mean by hunger. Hunger is a form of trauma. 42% of our community is food insecure. What do we mean by trauma? Gun violence is a form of trauma. In the Hill District, where our organization is, we have triple the homicide rate that we do in Allegheny County. Homelessness is a form of trauma. There are currently 28,000 people on the waiting list in Pittsburgh waiting for public housing. We also know that trauma leads to, obviously, bad behavior. There was recently a screening in the state of Pennsylvania conducted by Department of Corrections that found that out of the inmates in the Pennsylvania prison system, 80% tested positive for post-traumatic stress disorder. We are right now in the brink of launching a new initiative which we are calling Trauma-Informed Community Development. We know that trauma-informed care has a very important place in healthcare these days, and so we would like to extend some of that learning to community development. We're looking for trauma-informed community development. We need, however, to connect these data points, because currently these data points about the effects of trauma, the experience of trauma, are actually not being used by healthcare providers when they are making their screenings. This is why we've engaged in this partnership to design a tool that enables us to connect those data points.
Yeah, so basically the Focus Pittsburgh has collected a lot of resources and put a lot of efforts. It's trying to improve the well-being of people in the health district of Pittsburgh. But there is actually a problem. Like, how can we determine whether what specific things those people need? And so they actually, Focus Pittsburgh is actually using a very good way to collect information, because they physically located in the health district and interact with people in the community every day. But the problem is this method is not efficient. So the very typical method we use is a survey. And then we actually, the survey we call is a well-being skill. So then we will actually do a comprehensive evaluation on the people, and then we have physical health, mental health, socioeconomic status, a relationship, and also spiritual situation. And but the problem is if you only just create a survey and give it to people and ask them to provide the information, sometimes you actually will not get the information you need, because they will provide you false information. So that we will, what we will do is we'll ask them to do a physical exam and mental evaluation, and also we'll use mobile apps to collect information, just like the one previous presentation mentioned. You can use mobile apps to track them, like their sleep quality, and then we can integrate the data together and visualize them, and we can use statistical models to prioritize their leads. We actually have one specific example. So, for example, if a person, his name is Tom, and he is smart, well-educated, and he's very capable of doing his work. But the problem is that he, in recent years, he changed his job a lot, and he's in a very poor financial situation, and his relationship with his family members are terrible. And if you only do a very simple survey, like it's a financial situation, you probably quickly conclude that he needs financial support. And then you provide a lot of resources into that, but whether that is very effective or not, it is helpful. But actually, if we use this comprehensive evaluation, we figure out that this person actually has a traumatic experience in his childhood. So his resilience skill is poor. And basically, every time he's under pressure, and he will give up very quickly, and he will start to blame other people or take some extreme actions. So that is actually the fundamental reason behind the job change and also the poor relationship. So then when we design the intervention, we can actually provide resilience training, help him to handle the situation. So then he actually can find a job himself and keep it, and also stay in a good financial situation. And this is a much better outcome, and so it is much more effective. So it will save money and get effective results.
Hello everyone, I'm Wen Li from University of Arizona Eller College of Management. I'm going to talk about asthma surveillance using social media data. This is a joint work with my advisor, Dr. Sudha Ram, and 3 of our co-authors from PCCI in Texas. So first, asthma is a very serious problem in the U.S. About 25 million people in the U.S. are suffering from asthma. A lot of them end up in the emergency department. And a lot of times, the emergency department is not really well prepared to deal with the onslaught of asthma patients. So, however, if we have accurate and timely asthma surveillance data, it could guide the intervention of asthma to reduce the asthma social burden, and it could improve the life quality of asthma patients. However, according to CDC, the current asthma surveillance system is done by collecting data at the state and the national level. So naturally, such data has lag time for months or years, and very limited municipal level data are available from CDC. So can we build a model to do asthma surveillance in an accurate, timely, economic way? Turns out we found out that Twitter is a very good source of data. We found that there are people, when they are having asthma attack, they tweet before they reach for their inhaler. This is very interesting because they actually give us insight about how many people are having asthma attack. Of course, there are a lot of noise. There are true asthma tweets like, I'm having an asthma attack, I have to go to my doctor. And there are noise like, I'm having an asthma attack because you take my breath away. So our first task is to collect social media data and extract signals from social media tags. So we combine various NLP feature generation methods, including unigram, bigram, frequency analysis, negation model, lens analysis, and POS tag, and along with various classifier machine learning methods to extract signals from social media tags. Another important step is geolocation instruction. So to its geolocation can be identified by 2 fields. First is coordinates, next is location. So we can use latitude and longitude mapping and address resolution to identify the location for each tweet. So we collect social media data of Twitter streaming API. 18 different asthma-related keywords were used in this study. About 15,000 tweets can be collected from all over the world per day. And in this study, we were using 8 months data. Within an 88% of our accuracy, we can effectively extract signals from social media tags. And about 20% tweets, geolocation information can be identified as one of a U.S. state name. So on the state level, we report the correlation between CDC asthma prevalence in 2013 and our asthma Twitter data set. We found that after the signal extraction process, the correlation coefficient can improved from about 13% to almost 17%, which shows that our methods are very effective to do the asthma surveillance at the state level. On the municipal level, we report the correlation between asthma aggregate data of hospital visits from 28 hospitals in the Dallas area, which using asthma as a primary diagnosis code, and our asthma teacher data set. We can find that after the signal extraction and location extraction, the data can be significantly correlates with our asthma teacher data set. So now we are still working on predicting asthma-related ED visits by using big data, which means we are using not just the social media data, we are using environmental sensor data like weather data and pollution data. And the details about the signal extraction will be presented in the forthcoming workshop on information technology and system. Thank you.
Good afternoon. My name is Feng Mai. I'm from Stevens Institute of Technology. This is joint work with Dongil Ko and Joshua from University of Cincinnati. So the topic of our talk is managing paradoxical tensions to improve patient satisfaction, a view from the patients through user-generated online physician reviews. So we do have the longest title of this panel, but the motivation of our work is actually very simple. When consumers go shop for service, healthcare service included, consumers would like to receive the service fast, so they do not want to wait. They also want the service to be high quality. But however, in the healthcare settings, when patients go see a physician, these two objectives are contradictory to each other. Because according to basic queuing theory, we know that whenever a physician spends, on average, longer time on a patient, then that will result in longer waiting time of other patients. So we do also have the best animation of the panel. So that is the notion of paradoxical tension. That is, we have two contradictory objectives working together, and we are looking at ways of resolving that paradoxical tension from a patient review point of view. So this is our research framework. We are asking two research questions. The first one is, what exactly is the role of waiting time in that picture? That is, does waiting time have significant impact on patient satisfaction? Also, does waiting time have a moderation effect on other aspect ratings? In that sense, we are dividing the other aspect ratings of online patient reviews into individual healthcare measures and individual health service measures. So the healthcare measures would be on the medical side. For example, how accurate the diagnosis is. The individual health service measures would include the manner of the physician or the staff. So you might think that House MD is going to have a 5-star rating on the IHC measures, but 1 star on the IHS measures. The second research question is that given that we have the paradoxical tension between the conflicting objective of waiting time and quality of care, is there a way for healthcare providers to develop a strategy in order to improve the patient satisfaction? We collect our data from vitals.com, and we have over 272,000 physician-level observations. We have the aspect ratings and textual comments of all of the physicians. We also control for years of experience, major specialty of the physicians, also a zip code level demographic data. Let's get to the result. Our first result is the main effects. We confirmed that both individual healthcare and individual health services factors are important in terms of influencing the overall patient satisfaction. So I forgot to include the focal variable, that is the log waiting time, into the model. But we used OLS and instrumental variable regression to confirm that log waiting time is also an important predictor variable in terms of determining the overall patient satisfaction. In terms of the interaction effects, we see that log waiting time has a significant negative moderation effect on accurate diagnosis, which happens to be one of the most important predictor variable, the main effects of the overall patient satisfaction as well. In addition, we find out that after the healthcare encounter, if a physician has high follows-up follows up after visit rating, then that is going to attenuate the negative impact of long log waiting time. So in terms of interaction plots, this is what we find. So that is, even if the accurate diagnosis is good, if the patient waited for too long, then that can potentially undo the benefits brought by accurate diagnosis. However, if the physician has a nice follow-up strategy, that can potentially attenuate the negative effect of long waiting time. So overall, in conclusion, our results from patient review, we found out that patients do care about both healthcare as well as the service component provided by the physician. We find out that the negative impact of the waiting time is going to manifest itself in two ways. It has direct negative impact on the overall rating, and it also negatively moderates one of the most important predictor variables, that is the accurate diagnosis. Finally, we do find out that following up after visits can be a strategy for physicians to use in order to overcome the negative impact brought by long waiting time. Thank you.
Good afternoon, everyone. I'm Nadi Gunawardana from National University of Singapore. I'm a IS PhD student, and my supervisor is Dr. Sharon Tan. Today, I'll be presenting our research work on titled "Do Online Communities Help Patients to Achieve Health Goals? The Role of Subgroup Cultures and Progression Spiral Effects." As we all know, online healthcare communities are gaining increasingly popular, and these communities provide patients to set healthcare goals and work towards achieving those goals with the help of the community. So it is interesting to see the actual effect of these communities on achieving individuals' healthcare goals. So in this research, we are going to address two research questions. First, how could online healthcare networks help individuals to set and achieve health management goals? And second, what are the underlying mechanisms of influence on patients' goal progress? For analysis, we are using a case study methodology. Data is gathered from a popular online healthcare community called dailystrength.com. The special interest group of obesity was selected because weight management goals are more dependent on individuals. And from this community, we've gathered information from self-created healthcare goals, information such as goal completion dates, moods, progress levels, descriptions, and social support was gathered. And analyzing 200 goals, we found out that there are 7 goal achievement trends exist in this community. So through stratified sampling, we have selected 5 goals from each category for in-depth qualitative analysis. And our findings shows that there are 2 distinct categories of goal achievement. One set of goals, they always has a positive trend, but certain goals, they do not progress. Sometimes they end up gaining more weight than the beginning. And then we did a content analysis to see why this effect is happening. So we found out that there are 3 mechanisms of influence triggered by social sharing: contagion, social comparison, and empathy. Through these mechanisms, individuals get influence, and this will reflect on their success. So through similarity attraction, similar patients get attracted to each other, creating a spiral effect. So these are some of the community examples for 3 different types of mechanisms. And we found that there are 2 types of spiral effects. First, a positive reinforcement spiral. For example, those who are more enthusiastic with their goals and those who commit to their goals, more, attract patients who are also enthusiastic and those who have a better commitment. So they tend to create a subculture, influencing each other to achieve their goals in a better manner, creating a positive spiral effect. Conversely, those who struggle with their goals and those who have emotional struggles attracts those who are also struggling with goals. So this creates a culture where individuals, with the exchange of support, individuals get more comfortable with their current weight, so that they'll tend to maintain their current weight, or sometimes end up gaining more weight than the beginning. So when we look at the type of support exchange in these two types of reinforcement spirals, in the positive reinforcement spiral, more appraisal support is exchanged, and in the negative reinforcement spiral, more emotional support is exchanged. And implications, this study gives theoretical and practical implications. Theoretical implications to the literature on social influence, goal setting literature, and we also identified the differential effect of type of support on patients' healthcare behaviors. And practical implications, because we identified the importance of promoting a positive culture in online communities. It gives implications for practitioners to create a positive culture where they promote better healthcare behaviors. Thank you.
All right, now we have time for questions from the audience. While we're waiting, I wanted to ask you if you could tell me a little bit about, so I'm kind of really interested in the type of methods behind what you're doing, and the overall topic of adverse drug event detection is great. What's the most important thing that would be done with your model?
So the most important thing, in my opinion, is we need to identify a data source that we can align the training corpus with. So we have a Twitter discussion or forum discussion containing drug names and medical conditions. And at the same time, there are reports in FDA that contain drug indication and adverse drug event, and aligning the data with the social media text we have, we create a weekly labeled data set. And our training model is based on a 2-layer of logistic regression, which classify the relation indicated in the text. And we use EM algorithm to conduct the learning iteratively. And over the time, our model will rule out the noisy label in the training corpus and create more robust model for classification on the predicting corpus.
Well, so let's say once you're done with that, then what is done with the results of that model? Is it the FDA going to be able to detect bad drugs early? Are pharmaceutical firms going to be able to learn that they have a marketing problem? Like, you told us what?
Okay, so what we observed from social media is there are a lot of information, especially on Twitter, regarding the negative side of the medication. So if a drug is reported for adverse event, it will create a bigger voice in social media like Twitter. And it will be important for pharmaceutical companies to manage their social image regarding how people's perception for their treatment. And also those information contain patient experience about their adverse drug events. And FDA can use this information to accumulate evidence to build their drug safety profile. So with the additional evidence from social media, they can probably identify risky drugs earlier than they used to if they only use single data source.
Okay. Please.
Hi, Raymond Uy from National Institutes of Health and NLM. I have 2 questions, if it's okay. The I Am Healthy program, I see it has a lot of potential, but because of the limited time, it's a little vague to me what HIT intervention is being used to address. Is it a mobile health application, telemedicine application?
Yeah, so this I'm Healthy system, first we will design this well-being skill. So that is basically it's a survey, and we'll put that into a mobile app, At this moment, it's still in the development stage. We'll also have a EHR system that will be used to store the information collected from those study participants. And we'll use multiple mobile apps to collect some information from the study participants. For example, just like their sleep quality. So we'll actually use a mobile app, and then it will combine with the Fitbit. So it actually can automatically determine the situation of this person's sleep quality. So they do not need to enter anything. We also can monitor their physical activities and also the places they have been. So that these can be used to validate the answers in this well-being skill. So we want to get very accurate information from those study participants, and then we will combine them all together and put them into a statistical model, like a structural equation model, and to prioritize those domains, just like the example I gave. So then we'll determine which specific domain we should focus on, and then provide the intervention.
So just correct me if I'm wrong. You're going to do a needs assessment first before developing the app, and the app would address specific needs that are directly surveyed?
Yes. So the intervention will actually. Are you talking about the intervention?
Yep.
Yeah, for the intervention, some of them we can use mobile apps. So just like, for example, again, for the sleep quality, we actually can provide some interventions using mobile apps. And so then we also can use mobile apps to just provide some reminders, remind them eat more vegetables, drink water, things like that, or tell them the activities in the community, encourage them to attend those type of interventions.